Hello, welcome to my neurological physical exam video. I started off by introducing myself and gaining consent from the patient. Here I conducted the mini mental examination and I asked for the date, the current US president, and the city we are currently in. Now let's check the first cranial nerve, the olfactory nerve. I got the patient first to cover one nostril with their eyes closed and identify a familiar smell. This was next done on the opposite side. Here I checked the second cranial nerve for visual acuity with the Snellen pocket chart. I had the patient hold the chart at a half-hand distance, close one eye, and read the smallest line that they could. Here I tested for visual field. I stood 1 meter away from the patient, had them cover their eye with their palm, and brought in fingers from all angles to make sure they could see. This was next repeated on the opposite side. Next, I performed the fundus examination. I confirmed with the patient that they are not wearing any contact lenses, and with the ophthalmoscope, I stood at a 20-degree angle and came in towards the eye and came as close as possible. I made sure the patient continued looking straight and focused on the far wall. I ensured that there are no blurred margins, the optic disc is well defined and orange yellowish in color. There is normal cupping with cup to disc ratio, no clipping of blood vessels, and a healthy optic nerve and macula. Now we'll go through the pupil light reflex. I had the patient look at the far wall as I shine the light from the far side looking for pupillary constriction. Here I checked that the pupils constrict with light. Here I did the swinging light reflex. I swung the light from the side checking for consensual eye constriction. Here I checked for accommodation. I had the patient look at the far distance and then at my finger, then at the far distance once again. While I'm here, I also checked for convergence. I had the patient follow my finger as I move it far and close. Moving on to cranial nerves 3, 4, and 6, I began performing the H test, where I had the patient follow my finger without moving their head as I stood eye level 1 meter away. The patient kept their head center at all times and was able to follow dextroversion, dextroelevation, and dextrodepression. I did not notice any nystagmus or diplopia. Next, I will be checking the fifth cranial nerve's motor component. I had the patient close their eyes tightly and clench their teeth, and I checked for the muscle tone of the temporalis and masseter muscles. I also checked the sensory component of the trigeminal nerve. I had the patient close their eyes and say yes to touch sensation. This was done symmetrically, and I elicited the touch on the forehead, cheek, and jaw. Now checking the pain sensation of the face, I first demonstrated it to the patient on the back of their hand by giving them a dull and sharp sensation. I next repeated this on the face and made sure the eyes stay closed. I ensured to hit the different parts of the trigeminal innervation, the ophthalmic, maxillary, and mandibular branch. Next, I did the corneal reflex. I had the patient look up and away as I touched the cornea with the twisted end of a cotton ball. Now onto the seventh cranial nerve, I asked the patient a couple of questions and checked for facial expression. I also got the patient to close their eyes as tightly as possible as I tried to open them. I also got the patient to lift their eyebrows and I checked for forehead wrinkling. I also got them to puff out their cheeks and resist my movement. And lastly, I had them smile. I also asked if they had lost in any taste sensations or if they've been hearing louder than usual. Next, onto the 8th cranial nerve, I whispered in the patient's ear and had them repeat the phrase to me. Next is the tuning fork test. I tested with the Weber test first and placed the fork in the middle of the forehead, testing for lateralization. Next, I did the Rene test. I placed the stem of the tuning fork against the mastoid process behind the ear. The patient let me know when they no longer felt a vibration. Then I moved closer to the pinna, checking for air conduction. Now onto the 9th and 10th cranial nerve. I got the patient to open their mouth and say ah. Here I checked for the soft palate elevation, medial curtain movement of the posterior pharynx, and uvula is midline. Onto the 11th cranial nerve, I put my hand on the patient's cheek and had them turn their head against resistance. I checked for the strength and compression of the sternocleidomastoid muscle. Finally, for the 12th cranial nerve, I had the patient put their tongue out and I checked with the flashlight for any fasciculations or deviations, and also had them stick their tongue out and move it from side to side. It was symmetric. Onto the motor exam, here I am checking for bulk. I'm lightly squeezing the upper and lower limbs to check for atrophy. I check the forearms, the biceps, the calves, and the thighs bilaterally. Here, I check the patient's muscle tone by observing that the muscles are fully convex in the upper and lower limbs. I had the patient let everything loose as I moved the limbs passively to feel for any resistance. Here, we checked muscle strength. I began by assessing the muscle strength by having them flex and extend the upper and lower limbs, including the wrist, ankles, and fingers, and having the patient push or pull against the resistance. Moving on to the deep tendon reflexes, here I check the bicep for C5 to C6 innervation. Here I check the tricep reflex from C6 to C8 innervation. I also check the brachioradialis reflex here, C5 to C6. Here I check the patellar reflex, which is innervated from L2 to L4, and also the ankle or Achilles reflex, which is innervated from S1. I also conducted a Babinski sign test. A positive test would occur if there is fanning of the toes. Now we'll be checking sensory function. First, I started with touch sensation. I showed the patient what it would feel like, then I got them to close their eyes and tell me when they felt the touch on both sides. Now checking pain sensation, I had the patient on the back of their hand identify sharp and dull pain sensation. This sensation was also checked on the upper extremity and lower extremity, and I assumed that the temperature sensation is normal if the pain sensation was normal as well. Now checking for vibration sense. Using the tuning fork on the distal interphalangeal joint, I let the patient know when they felt the vibration as well as when it stopped. I also checked the vibration sense on the distal hallux. Next is testing for proprioception. I held the patient's finger joint and oriented the patient to left, right, up, and down, and I had them repeat to me left, right, up, and down, depending on the direction I'm moving them. I also did the same for the toe. Here I check for discriminatory sensation. Using a paper clip, I told the patient when they felt 2 touches or 1 touch. Here I am giving the patient a familiar object and getting them to identify it with their eyes closed. This is checking for stereognosis. I also checked for graphesthesia by writing a number on the patient's palm and getting them to identify it. Next was point localization. I got the patient to identify different regions I touch with their eyes closed. Next, we'll be moving on to cerebellar function. I started with the rapid alternating movement test. This assesses for upper motor neuron, basal ganglia, as well as the cerebellum. Slow, clumsy movement would be noted as dysdiakinesia. Next was the finger to nose test. My index finger was placed in front of the patient, and I got them to touch my index finger, then their nose, and repeated this. Next was the finger pass pointing test. This was conducted, and if there was an overshoot, this would be known as dysmetria and would suggest an intention tremor. Next was the heel to shin test. I had the patient run their heel up to their shin, testing for cerebellar function. First, with the normal gait, I checked for the posture, balance, and swinging of the arms with movement. After this was the tandem walk, which is walking heel to toe, and then walking on their tippy toes, testing for plantar flexion, and return on their heels, assessing for dorsiflexion. And next was the leg hop, where I had the patient hop on one leg. Here I had the patient put their feet together as I tried to shake them off their balance. I repeated this with their eyes closed, and that is called the Romberg test. Next, I checked for pronator drift. I had the patient stand with their arms out and supinated while I pushed them down, and they returned back to their original position. I repeated this with the patient's eyes closed. And this concludes the physical examination for today. I thanked the patient and addressed any concerns, and thank you for watching.